It changes. It
No.
changes now.
No, I think it doesn't change when you put full screen.
Okay, okay. Let's go back then to the previous form.
Yeah.
So it changes now, yeah?
Yeah.
Will remain in this form because it doesn't work in full screen. I'm sorry about that. But I think it's convenient like this also, yeah? Okay, so we'll have the direct mechanism, like I said, like when a pedestrian is hit by a car, for example, or in case of bullets, for example, that hit a part of our body. So we'll see when we'll describe all types of fractures that this mechanism is very dependent on the area. So, and the non-direct mechanism, which mainly is more frequent than the direct mechanism, may involve several situations. Like, for example, the torsion mechanism, when the a part of a limb is turned around, so is rotated, forcingly rotated. So this mechanism, for example, you can meet during the practicing ski, when the ski will hit an obstacle in front, and then the body will continue its movement, and so the lower limb is forcingly rotated. Other mechanism will be the bending or the flexion, like you can see in this right image, yeah, when for example, this is also the situation is also from the skiing, yeah, because you see the boot, the edge of the boot will be the place where we'll get the bending of the two bones of the leg, and will produce a fracture. Also, we can get a compression mechanism. For example, we have on the left side here this image referring to the vertebral column, when one of the vertebral bodies is compressed between the other two, under and beneath and above the fracture site. And also we may get another mechanism, which is traction. For example, in patellar fractures or in olecranon fractures, we may get that mechanism which will displace the two fragments apart one to another. The displacement of the fragments depends also mainly on the muscle traction over those fragments. So usually the displacement at a fracture site is done by the muscles which are inserted on those fragments. So the muscle traction is responsible of the displacement. And mainly we can have four elementary types of displacement. The first one, well, it's not the first one, it's one of them only. So, but let's say the first one may be the lateral displacement, which is called also translation. You can see this image, which is on up left side. So in this type of displacement, the two bone ends are displaced laterally. Then we may have the so-called longitudinal displacement, or also called overlapping, when the two bone ends will displace on the longitudinal axis of the bone, and mainly the bone may get shortened, or in the opposite situation, when we have a distraction, the bone ends may get a distance in between. Another one is the rotation, when the two bone ends are rotated one to another. We can see on the right side, which is also a displacement which is mainly seen in those limb segments which have two bones, like for example the leg and the forearm. And of course, we've seen before the angulation displacement. Here is the angulation, where when the two bone ends will not be in the same axis, they will get an angle in between them of a different size, doesn't matter, but anyway they'll get an angle which will define this type of angulation displacement. Here are also some drawings. You can see here how the muscle insertions at the level of the bone ends of the bone ends, yes, will determine the displacement of the fracture. Like I said, the main reasons of displacement are the muscles and the gravity, depending on the position of the limb. The same thing here on the right side, we have an X-ray of both bones leg fracture, tibia and the fibula, and when we'll see the longitudinal displacement, meaning that the leg is shortened, and also the lateral displacement, meaning that the two bones are laterally displaced. We may have undisplaced or displaced fractures, but unfortunately the most of the fractures are displaced. The non-displaced fractures are of course easier to treat because there is no need to perform the reduction of the fragments, only we have to immobilize them in order to obtain the union of the bone. Here are some examples also. This is a fracture of the femoral neck. You can follow my prompter. You can see the fracture line, which is a non-displaced fracture. You know, the position of the bone is not changed. In comparison, or let's say in opposition with this type of fracture at the same level, so this also a fracture of the femoral neck, where we can see the displacement of the fragments. So this one is a displaced fracture. Again, here is a non-displaced fracture. We can see on our left side, which can be easily treated by immobilization. According to the integrity of the soft tissues around the fracture, we can divide the fractures in closed and open. The great majority of the fractures are closed, meaning that the soft tissues around the fracture site are intact. So this, but a certain percentage of these fractures may be open. Opening of the fractures meaning that the fracture site has a communication with the exterior, meaning that the soft tissues and the skin mainly above the fracture are also damaged, so that they allow this communication between the exterior and the fracture site. Here is a closed fracture. We can see the distal extremity of the radius, so a fracture of a distal epiphysis of the radius. Please be attentive that all these fractures that are only examples now will be detailed during the next lectures, when we'll talk about fractures of the upper limb, lower limb, column, pelvis, etc., etc. So don't get into panic that you don't understand about the fracture that I'm only mentioning now, because they will be described in in the next lectures. So this one is a fracture of the distal epiphysis of the radius. It's a closed fracture. And here we have the X-ray, which corresponds to this type of fracture. And here we have a fracture of the same level, but which is also opened, because you can see that at the level of the ulnar fracture, a bone end is out from the fracture side between, I mean, through a break at the level of the soft tissues, especially the skin, and communicates with the exterior. So that's mainly what open fracture means. Also, another criteria for classification refers to the location of the fracture. Especially when we talk about long bones, probably you know from the anatomy, if you remember from the first year, that a long bone is composed of a diaphysis and two epiphyses, and in between the diaphysis and the epiphysis, we have the metaphysis. We have also to mention the fact that the metaphysis, as a, let's say, as an anatomical site, exists only in children. So the metaphysis is that part of the bone which is responsible for the growth in length of long bones. So at the age when the growth of the bones is completed, then the metaphysis will disappear, in fact, as an anatomical formation. But even in adults, we still use this notion of metaphysis in order to point the area between the epiphysis and the diaphysis for the description of the fractures. So sometimes the epiphysis fracture may be intra-articular. We'll see that because this is also a criteria of classification. Here are some X-rays in order uh, to explain more what I've said before. So this is a fracture of the middle third of the tibial diaphysis, like we can see. This is a fracture of the distal epiphysis of the tibia, exactly like this one. All these fractures being extra-articular fractures, so no fracture line goes into the joint. This is very important for the treatment. Other fractures, like this one, is an articular fracture. You see, this is a fracture of the proximal epiphysis of the tibia. But like you can easily see, it's a comminuted fracture, meaning that it has many fragments, but at least one fracture line goes into the joint and damages the articular surface of the tibia. That's very important because the articular surface must be restored during the treatment. We'll see very soon that. Also, another one, another articular fracture. This time, this one is at the level of the proximal humerus. This one is at the level of distal femur, and another one at the level of the proximal tibia, which is also called the tibial plateau. The fracture line may be simple or complex, meaning what? The simple fracture is that one with two fragments. The complex fracture is that one that has more than two fragments. So we may have a fracture with three fragments. Usually the third fragment is the wedge form fragment, or we may have a comminuted fracture, which means that we have more than 3 fragments at the fracture site. Also, we may have segmental fractures, meaning that at the level of the long bone, we may get 2 fracture sites, one above the other. And finally, there are the so-called burst fractures, which are always comminuted fractures when the fracture line is totally irregular, so barely you can classify this type of fractures in one of the elementary types. And let's have some examples. Here is all these are simple fractures, yeah, because they have only 2 fragments. On our left side, we can see a so-called transverse fracture. The transverse fracture, the fracture line is horizontal. And this fracture has a big advantage during healing, that this aspect of the fracture line makes it very stable. Stable means that after we immobilize this type of fracture, we don't expect that the fragments will be displaced furthermore. In addition, if we put, for example, this patient with this leg fracture in a cast, we may even allow the patient for weight bearing, because we'll get compression forces at the level of the fracture line, which are very favorable to bone union. Whatever the treatment will be, even if we put the patient in a cast or the patient will undergo surgery, for example, by intramedullary osteosynthesis, then whatever the treatment will be, due to the fact that we have this transverse fracture line, weight bearing will be in favor of union of the bone, because it will generate compression forces at the level of the fracture line. Well, in a position with this situation, we'll have the other two. In the middle, we'll see an oblique fracture line. Well, this one is not stable anymore, because like you can see here, if the patient will be allowed for weight bearing, then the fragments will slip one to another, and we may get secondary displacement of the fragment. So that's why usually in this type of unstable fracture, the patient, after fixation of the fracture, will not be allowed for weight bearing. The same thing may happen with this spiral fracture, which is also unstable, exactly like the oblique fracture. Some examples. So we refer to the leg again. On the left side is a transverse fracture. Both bones are fractured. Well, the fibula doesn't matter too much, because in humans the fibula has not an important let's say function in weight bearing, because the tibia has about 98% of the weight bearing, so we don't care very much about the fibula. But here on the right side, we can see a spiral fracture, which is also unstable, like I said before. So these are x-rays for these two types of fracture. Now we can see here what I've explained before, that fracture with 3 fragments. So usually the third fragment, this one here, which has sometimes, or let's say in most cases, the shape of a K, you know, it's like a K. We have the 2 main fragments, the proximal and the distal, and in addition, we have this third fragment, which also makes the fracture quite unstable when we choose the method of treatment. And here we have the comminuted fracture. You see there are many fragments at the fracture site. This is probably the most unstable fracture among all, and we may even get in this situation a bone deficit due to the fact that these fragments are spread everywhere in the soft tissues. That will be very difficult to restore the shape and the length of the bone in normal conditions. Well, I won't go into details now because it will be described at the fractures of the leg. And the other one, which I've mentioned before, is the segmental fracture, which has two fractures lying, in fact, one above the other, which will make that the intermediate fragment will be very unstable and should be properly reduced in order to restore the length of the bone. Well, we have a classification system which is used for all the fractures in our body. It's called the AO classification system. AO comes from the French words association d'osteosynthèse. That's because this uh, osteosynthesis association, because that's what I've told you in those French words, in English means the osteosynthesis association. Uh, this group of persons, which was formed in, I think, in the 60s or maybe in the 50s, I don't remember exactly, was formed in Switzerland with the specific task to make a classification system for all the fractures in our body. So they did this, but like I said, due to the fact that at that time French language was still of large circulation in the scientific world, that's why the name of this association was in French. Besides, the location of this association was in the French part of Switzerland. But now, because that was the name of this association at that time, we'll still refer to it like AO, Association d'Osteosynthèse. Okay, let's go back to our classification. According to this classification system, the fractures of long bones are divided into three main types. Type A, like you can see here on the first row, the first row, we can see that all these fractures are A type. A type meaning that we have a simple fracture. So a fracture with two fragments. Type B, the second row, are the fractures with three fragments. And finally, type C are the fragments are the fractures with more than three fragments. In fact, what we used to call the comminuted fractures. And inside all these groups, we have subgroups uh, nominated by figures. So we may have A1, A2, A3, and so on, depending on the aspect of the fracture site. For example, here, A1 is spiral, A2 is oblique, A3 is transverse. Well, also in B, we have different types depending on the aspect. In C, the same thing. And all these nominations are quite peculiar for all types of fractures we can have in our body. I must tell you from the very beginning that even us who are specialists in orthopedic surgery, we don't know by heart this classification system because it's not necessary. If you really want to precisely diagnose, or let's say formulate a precise diagnosis of a fracture using these figures and letters, then you should look in the classification system. So you only have to open that book with the classification system and find the pattern of your fracture and nominate it. So what you really need to remember is the principle of this classification system, not exactly the figures and letter of each fracture, because we'll meet this classification system along our presentations. Also, we have to emphasize the fact that we may have fractures on normal bone and on pathologic bone. Of course, the traumatic, so-called traumatic fractures are fractures on normal bone. And the great majority of the fractures are on normal bone, which has a specific resistance to mechanical stress. But other fractures may be on the pathologic bone, and we may recognize this type of fractures from the very beginning, that they will be produced at a minimal trauma. Usually, the normal fractures on normal bone need a violent trauma. I mean, what I said before in the definition, a trauma which exceeds the resistance of the normal bone. So one violent trauma may lead to a fracture. Or we have also, let's say, a more rare condition which refers to a mild repetitive trauma. For example, uh, let's say in the army, for example, but not now, because now soldiers are not marching anymore. Soldiers are transported with special vehicles. But let's say about 100 years ago, maybe in the First World War or maybe in the Second World War, when the soldiers were marching tenths of kilometers every day, due to mild repetitive trauma at the level of the bones of the feet, for example, may get stress fractures. So those fractures were also on a normal bone, but that normal bone was not uh, didn't get a violent trauma, but like I said, a mild repetitive trauma, also leading to a fracture. And finally, I've told you about the pathologic bone fractures, meaning that the resistance of the bone is not normal. So due to different reasons, the bone becomes soft, and so even minimal trauma may lead to a fracture. For example, we have this drawing here, and we can see that in the middle of the bone, it's a femur here, yeah? The metaphysis of this femur, we have a tumor. So the bone substance was replaced by a soft tissue, a tumor tissue, which of course diminished progressively the resistance of the bone. So this one is called a pathological fracture because it happens on an abnormal bone. The reasons for which a bone may get softened are different. For example, we have some metabolic disease. The Paget disease, it's a metabolical condition of the skeleton when, due to, like I said, some metabolical changes in the bone structure, I won't go into details, then the resistance of the bone, so the mineral substance of the bone, which usually is responsible for the mechanical resistance of the bone, is diminished, and that's why those persons may easier get fractures. Also, some other disease like the Lobstein disease, which is periostal dysplasia, or probably the most frequent reason of softening of the bone will be bone tumors, primary or secondary bone tumors, like known under the name of metastases. So primary bone tumors or metastases will replace the bone substance by tumoral tissue, and the resistance of the bone will be hardly diminished. And also in old persons, especially in women after the age of 50, metabolical changes induced by hormonal changes will soften the bone structure, and those persons may get easier fractures at a minor trauma. So this will be also a reason for these persons to get easily fractures. Besides, we may get some in infections, even in infections, usually chronic infections, called osteitis, meaning infection of the bone. The structure may be softened and the patients may also get pathological fractures. The treatment of these pathological fractures may be sometimes very difficult, depending on the reason for which the bone got the fracture. And I will refer mainly to the pathological fractures due to tumors. So the tumor surgery or tumor treatment is very complex. So, but anyway, we have to fix the bone whenever this thing is possible. We usually remove the tumor from the level of the bone, replace that area with cement, of course, surgical cement, special cement, and also fix the bone by osteosynthesis with different means of fixation like rods, plates, screws, whatever is fit for that area of the bone. Or sometimes we may even resect that part of the bone and replace it with a sort of prosthesis, which are called mega prostheses because they are very big and they have, by construction, special modules that will replace the resected area of the bone. Usually those fractures, or let's say the metastases at the level of the bone, are secondary to some type of malignancies, and mainly to breast and prostate cancer. Those are usually this type of cancers, of tumors, give metastases at the level of the bone. But fortunately, if we may say that, if we treat the main tumor, which is the breast or prostate cancer, then at the same time we may obtain the union of the fracture, of the pathological fracture of the level of the bone. While other fracture, other metastases like for kidney, lung, or digestive tumors usually will never go towards union, whatever the treatment will be for the primary tumor. Also, in some of these pathological fractures, we may use therapy with hormones. You know, this is an oncological treatment. I'm not very familiar with oncological treatment because these patients with tumors, beside the surgery which is done by us, will be sent to the oncologist in order to lead the chemotherapy and even the hormone therapy which may be necessary in this type of tumors. So it's a complex treatment, like I said before, in order to obtain the union of the bone after this type of fractures. Is more difficult than in normal fractures. What will be the physical examination of a patient with a fracture? Well, first of all, we'll see that there are some signs of probability for fractures or some signs of certainty of a fracture. We'll go one by one to describe them a bit. First of all, probably the most common sign, clinical sign of a fracture will be the pain. Every patient with a fracture will get pain. And the pain is localized normally at the level of the fracture site. So this will be the first orientation we may get for the physical examination for the fracture site. Then the swelling. So that segment of the limb will be bigger than the contralateral part, which is healthy. So if we examine by comparison the damaged part of the limb with the normal one, we'll observe only by simple inspection that that part is swelled. So it's bigger than the other side. Well, we can, if sometimes we are not sure about this change in the dimension, in the size of that part of the limb, we may even use, let's say, a measurement device in order to make objective this type of swelling. Then we may have a regional deformity. So also that examination must be done, I repeat, in comparison with the counterlateral side, which is healthy. So we may get the regional deformation. I mean the axis and the shape of that area of the limb is not the same with the healthy part. So the area is deformed, abnormally deformed. Also, the patient will have a functional disability. So he will not, I mean, the patient, he or she, will not be able to use that limb the same way it does on the counterlateral side. So normal function of the area is totally abolished or diminished depending on the site of the fracture and of the displacement of the fracture. So that part of the limb will be functionally impaired. Also, we may get a late ecchymosis. Ecchymosis, like you probably know from maybe physiopathology, an ecchymosis is the correspondence of an hematoma at the level of the skin. If the hematoma is profound, usually is in the middle of the limb, then at the surface of the limb, we may get this ecchymosis, which is also produced by blood migrating from the hematoma towards the skin. The hemosis in fractures is late, meaning that it occurs, is visible only after at least 24 hours after the fracture. We'll see that this is important to determine because in other types of trauma at the level of the limbs, like for example, sprains of the joints, the ecchymosis may be quite early. So we may get an ecchymosis in the first 6 to 8 hours, while the ecchymosis in fractures occurs no sooner than 24 hours. Okay, and we have signs of certainty, which will be loss of bone continuity. So loss of bone continuity, we may determine this only in those bones which are located under the skin. So by palpation, for example, we can palpate the anterior rim of the tibia. So the anterior rim of the tibia is located under the skin. So we can easily determine the lack of continuity of the tibia by palpation in a fracture at this level. Also, we may get abnormal mobility. So if we refer also to the leg, because we like to refer to the leg because it's very accessible to examination. If we grab with one hand the proximal extremity of the leg and with one hand the distal extremity of the leg, and we'll try to mobilize these two fragments, we'll see that in a fracture that thing will be possible. So we'll be able to angulate the two fragments one to another, which is of course impossible in an intact tibia. Also, we may see the lack of motion transmission. Let me give you an example. In a humerus diaphysis fracture, if the patient will try to abduct the arm, only the proximal fragment will follow this motion, and the distal fragment of the arm, together with the rest of the upper limb, will remain in a gravitational position. So will not follow the movement of the proximal fragment. And also we may have another sign which is called crepitation, meaning that in between the fragments of the fracture line, we may feel or even hear some crepitation when the two fragments move one to another. So pay attention that this sign of crepitation must not be searched on purpose when we examine a patient. If we accidentally determine that sign, that is okay. We can note it down that we determine crepitation. But we must never search it on purpose, because if we try to mobilize the fragments one to another in order to search for the crepitation, we may damage the soft tissues and or even open the fracture. So never try this on purpose. Well, after physical examination, we may have a sort of diagnosis which is not still a precise diagnosis. So we have an orientation diagnosis. The only examination that may lead to a precise diagnosis is the radiological examination. So the X-ray examination is the most important type of examination that we use in orthopedic surgery. And we need to take at least two positions of X-ray examinations. The standard positions are an AP which means anteroposterior view, and lateral view, which these two may also need sometimes to be completed by other positions like oblique or axial positions. But these two are mandatory for any radiological examination. Another principle will be that the entire segment should be included on the X-ray, meaning that let's say a correct X-ray must always have the joint above and the joint below the fracture site on the same X-ray. And sometimes we may need to take a comparative X-ray with a normal site when we determine, let's say, some congenital abnormalities of the bone in order to be able to make a correct diagnosis. In addition to the X-ray examinations, we may need a CT scan, especially in spine, acetabulum, calcaneus, tibial plateau, and vertebral column. So in our days, for example, a vertebral column fracture will not be precisely diagnosed without a CT scan or sometimes MRI. So all these additional examinations are necessary for some of the fractures, especially when it's a comminuted fracture, when it is an articular fracture, which will go to surgery and where we intend, in fact, not only intend, but where we need to restore the anatomical shape of the articular surface. In all these cases, we need an CT scan in order to see the number, the position of the fragments, in order to make a planning, a pre-operative planning for restoring the articular surface. Also, we may need a Doppler ultrasound if we get vascular complications, or sometimes even an angiography to determine the blood flow through the vessels. The fractures are often accompanied by complications. Complications may be immediate complications, meaning that these complications will occur after minutes to hours after fractures. So the time of these complications refers to minutes to hours after fractures. Then come the early complications, which occur in between hours to days after the fracture. And finally, the late complications, which will come after weeks to months after fractures. And all these types of complications may be local or general. Let's make some further considerations. Immediate complications, local. For example, the most feared of them are the vascular injuries. So like you can see in this drawing on this slide on the left side, a sharp fragment of the fracture may impinge over the brachial artery, because we refer here to the elbow area, may impinge over the brachial artery and produce a damage of the level of the artery with the interruption or diminish of the blood flow at the level of the upper limb, which is a very severe complication which may compromise the upper limb. So the lesion may be at the level of the intima of the vessels, which may lead to a thrombosis inside the artery. We may use the Doppler ultrasound and angiography, like I said before. And the immediate treatment must be established in order to regain the blood flow at the level of this segment. And here on the right side, you have an arteriography when we can see the contrast, the substance which is injected to make a contrast shows a complete stop of the blood flow at the level of the artery and the development of collateral circulation, meaning to trying to reestablish the blood flow at the level of the segment. Other complications may be neurological, referring to the nerves. So the same way that a fracture, a bone fragment may impinge over the vessels, it may impinge also over a nerve from the neighborhood. And we may get a contusion, elongation, or compression of the nerve. Well, the nerve complications depend on the anatomical status of the nerve. Fortunately, most of the nerve complications are functional, meaning that the transmission of the influx at the level of the nerve is compromised temporarily. So these complications are reversible and is due only to the changes in the metabolism of the axon, which is, like, you know, the long part of the nerve, which compromises the transmission only for a period of time. The other condition possible will be the interruption of the nerve, which is an anatomical damage of the nerve, which is not reversible and will probably need further surgery in order to re-establish the continuity of the bone, of the nerve, sorry. These conditions may be diagnosed especially by using an electromyography. Probably you know that electromyography is a let's say a paraclinical investigation which shows if the nerve axon is capable of transmitting the nerve influx or not. So it makes, in a way, a difference between the functional and the anatomical lesions of the nerve. Here you have an exploring of the radial nerve, where you can see that the nerve is anatomically damaged. Other complications, also immediate complication and also local complication, may be the open fracture. So open fractures usually happen in the areas where the bone is located under the skin. Let me give you an example. For example, let's say at the level of the leg, there are very frequent open fractures because, like I said before, the tibia is located under the skin. At the level of the thigh, for example, so the femur, we won't have open fractures so often because the femur is surrounded by a thick layer of muscles which will not allow easily for the bone ends to get to the outside. So open fractures are located in some specific areas where the bone is located under the bone. And we have again the most frequent example at the level of the leg. You can see when the bone ends have damaged the skin and are at the outside, and here is the x-ray of the same fracture. The open fractures are more difficult to treat like the closed fracture because especially due to the high risk of infection. First of all, we have the lesions at the level of the soft tissues, and then we have also the risk of infection because germs from the outside, from the clothes, from the skin, even from the soil may get into the fracture site and lead to infections. Other complications, immediate complications, will be um, the traumatic shock. It will be explained in detail at the lecture about polytrauma. The traumatic shock has a specific mechanism, a neurological mechanism, which will lead to hypotension and hypovolemy, which will be responsible for this traumatic shock. Also, from the site of the fracture, due to the fact that inside the long bones we have the bone marrow, which contains fat tissue. Some fat tissue may migrate from that area of the fracture by vessels to the brains or to the lungs and will be responsible for fat embolism, which is a very severe complications because in some situations it may lead to the death of the patient. Other local complications may be skin, soft tissue complications like these blisters you can see at the level of the fracture. So blisters have also some local vascular mechanism, which these blisters you can see represent accumulation of liquid at the level of the skin, and they are not very severe complication, but they are uh, they are not wanted, let's say. We don't like this complication because they will not allow us to operate the patient, especially if the blisters at the level of our incision, where we must perform our approach to the bone. If these blisters are covering our approaches area, then the surgery must be postponed, because if we go through these blisters, we risk to infect the bone site. So these blisters usually will be emptied. So using a pin, they will be pinned, emptied, and we have to wait until they heal and then do the uh, appropriate surgery. Infections at the level of the bone site of the bone fractured is also a very severe complication. That's because uh, the let's say the defending system of the bone is very weak. So if a germ or germs will go to the fracture site, the mechanism of defending for infection acts very slow and very inefficient. So that's why we must very much fear the bone infections, because by natural mechanism they will not be healed easily. So the diagnosis of infection will be done by clinical examination, by bacteriology, because we have to harvest liquid from the area and perform cultures in order to determine the type of germ which is responsible of the infections, and also by blood tests. We have some specific blood tests that can show us the evolution of the infection. One of them will be the number of white blood cells. The other will be CRP, which is the C-reactive protein. Fibrinogen, also level of fibrinogen, and the rate of sedimentation of the erythrocyte. So erythrocyte sedimentation rate is also an important blood test for infection. So infection diagnosis must be done by combining all these types of diagnosis: clinical, by biochemistry, and by bacteriology, which is, like I said, important to determine the germ. And after determining the germ, we must test the germ to different types of antibiotics in order to know which of them is chosen in the treatment of the infection. Because we need to administrate to the patient a targeted antibiotic antibiotherapy in order to destroy the germ. Well, usually at the beginning, when the patient comes to the hospital after an acute trauma with an open fracture, we don't know the germ yet, at least not at that moment. So we usually start with the general antibiotherapy until we have the results from the lab in order to narrow our field with a targeted antibiotic. The treatment of this infection will have also a surgical part and let's say a medical part. The surgical part will be done by the excision of the infected tissues, which is called debridement, and also the administration of these antibiotics targeted on that specific germ. Another complication, this time will not be an immediate but an early local complication, will be the compartment syndrome. Well, the compartment syndrome is in fact an increase of the pressure inside the leg due to the hematoma of the fracture. We know that every fracture is accompanied by a hematoma. This hematoma, which will develop inside the leg, will compress the soft tissues and mainly will compress the walls of the artery. And the walls of the artery being compressed, then the blood flow will be progressively diminished, and the blood flow in the periphery will decrease and compromise the leg. When we even may get necrosis of the peripheral part of the leg. It is important to take care of all the risk factors that may lead to this syndrome, like the fracture displacement and especially too tight cast immobilization of the segment, which may be responsible of developing of this syndrome. Here are some pictures. If this syndrome will develop, then we need to perform incisions all along the segment, this is also a leg, in order to release the wall of the arteries in order to re-establish the blood flow to the peripheral part of the limb. It may appear, usually it may appear in the leg or in the forearm. These are the most frequent parts where we can get this compartmental syndrome. We can see the leg here and the arm here that were incised in order to release the soft tissues. Other complications may be the deep vein thrombosis or the thromboembolic disease. Deep vein thrombosis consists in developing of the clots at the level of the veins of the peripheral parts of the limb due to immobilization or due to surgery. In our days, all these complications are prevented by administration of the blood thinners, of the blood anticoagulants. So it's a rule in the orthopedic surgery that all the patients that will be immobilized in a cast after a fracture or will undergo surgery for a fracture, all of them, but no exception, all of them will receive the thromboembolic prevention by administration of the blood anticoagulants. Other complications may be pressure sores due to bad immobilization or due to the casts which were improperly applied on that segment of the limb. Respiratory, like urinary infections, due usually to immobilization in bed in old patients. So in old patients, a fracture of the lower limb will lead to immobilization, and that may be responsible for pneumonia, for example, or urinary infections, which sometimes, if they are not properly controlled, may lead even to the death of the patient. Other complications may be late complications, which will appear usually after weeks after fracture. And the most common late local complication will be the delayed union. So usually a fracture must be healed, so the union of the bone must be obtained in about 3 to 6 months. Doesn't matter the method we have used for fixation, conservative or surgical. If after 6 months by using the X-ray examinations, we don't find the union of the bone, then we may be in front of the delayed union. If the union of the bone is not present even after more than 6 months, then we may speak about a non-union, which is also called by a pseudarthrosis. The main etiology of the pseudarthrosis might be improper reduction of the fragments, especially with an interposition of soft tissues in between the fragments. Mobility of the fragments because we did not apply a proper immobilization system. So the cast was not properly applied. Or the fragments were devascularized at the time of the fracture because of the lesions of the level of the periosteum. These types of pseudarthrosis or non-unions may be atrophic, hypertrophic, with normal of abnormal axis, or infected. Especially this happens after open fractures. Here is a pseudarthrosis. You can see at the level also of the leg after an open fracture, because we can see here the marks of an external fixator that the patient had before. This is a malunion. We can see that the axis of even if the axis of the bone is in a way preserved, but the healing of the bone was done with a very important lateral displacement. So this one is called not non-union, but malunion, meaning that the bone was healed in an improper position. Also, complications that may accompany healing of a fracture may be joint stiffness, especially after cast immobilization. The neighboring joints may get stiffed due to the mobilization for quite a long period of time. The The range of motion may be compromised, especially at the beginning after we remove the cast, and these patients must undergo physical rehabilitation. Also, we may get uh, arthritic changes in the neighboring joint, changes at the level of the articular cartilage, or avascular necrosis. If the vascularization of one of the bone fragments was compromised, then we may get bone changes on the X-ray, very suggestive for a vascular necrosis. And finally, a prolonged immobilization in a cast may lead to a reflex sympathetic dystrophy, which is a condition produced by the vegetative nervous system, leading to a local osteoporosis and pain of the level of the segment which was immobilized in the cast. Treatment of the fractures may be conservative, surgical, or functional. The main three steps in the treatment of a fracture will be reduction, immobilization or fixation, depending on the type of treatment, and functional rehabilitation. Reduction may be closed. Only in this situation, we only manipulate the fragments. So we try to reduce the fragments and put back them in the anatomical position only by traction over that part of the limb and maneuvering it in the opposite direction of the fracture. So we try to follow the way back of the fracture, of the mechanism of the fracture, in order to put the bone ends into the anatomical position. So the main maneuver we do at the beginning will be the axial traction, followed by other types of maneuver depending on the type of fracture. So this type of reduction, which is called external reduction, closed reduction, is the most valuable from the point of view of the healing of the fracture because it doesn't interfere with the fracture hematoma. So the fracture hematoma, which forms at the level of the bone ends, remains in place, and it will be responsible in the future for the formation of the bridges between the fragments in order to obtain the union of the fracture. So this external reduction, closed reduction, may be by manual, by hand, or instrumental in the case when we use the skeletal traction. For example, we have here an example of a skeletal traction when we introduce a Kirschner wire through one of the bone parts of the limb, and we attach to this pin a sort of orthopedic horseshoe which will apply traction in the long axis of the part of the limb. So this skeletal traction will be explained in details by our assistant because we have a special subject for this skeletal traction. Conservative treatment, also reduction, must be done under anesthesia, local, regional, or general anesthesia. So, of course, all these maneuvers of reduction must be done under anesthesia. After reduction, we must immobilize the patient in different types of casts. Different type of casts will also be explained by our assistant during the practical demonstration. So they are peculiar for all types of, for the two limbs or for the segments of the two limbs. So we don't we don't describe them now. So we'll use casts, splints, bandages, or ortheses. I suppose you know what ortheses are. So ortheses, if we have to make a difference between ortheses and prostheses, the prosthesis replaces a segment of a limb, and orthesis is an additional sustainer of a segment of the limb. So that's the difference between orthesis and prosthesis. And we have some examples here. So here is a cast, a plaster cast, which might be applied after traction, after reduction. Or we have here another type of cast for the upper limb. I repeat, all these will be explained by our assistants. We don't go into details now. Plaster cast may be accompanied by complications, by compressions or joint stiffness, like I said before, or pressure sores if the segment of the limb was not properly enveloped with, let's say, cotton before applying the cast. And there are some specific counterindications for the casters, like diabetes, insufficiency of the arterial circulations, blisters, or other skin conditions. Here is an example of a bandage, and here on the right side is an orthesis, like you can see, which is an additional support device for the upper limb, or for the limbs generally speaking. The reduction may be, like I said, closed reduction or open reduction. The advantages of the anatomical of the open reduction may be that it is an anatomical reduction. We may even replace part of the bone which was lost during the fracture if we have an open fracture, but it has these advantages because it may introduce germs at the level of the site of the fracture. It may damage soft tissues. It may produce stripping, which means devascularization of the bone ends, which may lead to delayed or non-union. Besides, like I said before, we will evacuate the fracture hematoma, which is not in favor of bone union. So whenever possible, I repeat, we prefer the close reduction in order to preserve the anatomical hematoma of the bone of the fracture line. Fixation, which is the second step, can be done with different fixation devices, like we can see here, screws of different types, plates with screws. The plates are always fixed with using screws, or some special devices for internal fixation, like dynamic hip screw, known also as DHS, or tension band wiring, like we can use for fixation of olecranon fractures or patellar fractures. So these tension band wiring are composed of 2K wires fragments together with the wire loop of the form of figure 8. So this type of fixation will be also explained again when we speak about the olecranon fractures or the patellar fractures. And also the gold standard of fixation for the fracture of the long bones refers to the internal fixation, intramedullary fixation, by using nails or rods. There are different types of rods and nails, usually locked inside the the intramedullary channel by using a static or a dynamic locking. You see here on this drawing, the rod has holes through which we introduce special screws which will fix the rods and in the distal metaphysis and in the proximal metaphysis in order to preserve the length of the bone and to prevent rotation of the fragments one to another. So there are different types of nails like puncture nails, gamma nails or retro nails. So they can be introduced from the proximal epiphysis of the femur, like in this situation, or they may be introduced from the distal epiphysis of the femur, this one being called retronail because they are introduced from distally to proximally, so in the, let's say, retro position. All those intramedullary fixation devices are very, let's say, physiological from the point of view of bone union because they don't interfere with the uh, fracture hematoma. They are usually introduced by using the X-ray image intensifier and performing a close reduction, so a previous close reduction, and after that the rod is introduced intramedullary. Also, we may use elastic intramedullary nails like ender nails. I only mention this only like a possible fixation device, but they are not used anymore because the rods are the preferred method in our days. Complications may appear also, may occur in this type of fixation, internal fixation, like infections. The rate of infection is usually around 1%, with variations depending on the fracture site, on the conditions of the hospital, the surgeon. There are many factors that may influence the infection rate, but mainly they are around 1%. Other complications may be secondary displacement, device failure, usually is a late complication, occurs in after a time after fixation, when the patient starts weight bearing. We may get the fatigue of the material of the implant, and we may get a device failure. And we may have also, even if the fixation was done by respecting all the principles, we may get a delayed union or a non-union. Of course, in these situations, the patient must be re-operated and the osteosynthesis must be redone. External fixators are used in open fractures. I mentioned before that in open fractures, the most feared complication is infection. So due to this, we are not allowed in open fracture to introduce osteosynthesis material. So metal is not allowed in open fracture site. So the only way that we can fix these fractures is by using an external fixation, which, which makes this from the distance. We can see here the external fixator. So it has some pins which are introduced in the fragments, and then these pins are united one to another by an external device, so that in the fragment side, at the level of the fracture side, we have no material. No inert material is allowed at the level of the fracture site. So this is the principle of the external fixator. They can be different types of external fixators that will be less important, but the principle has to be respected so that no material at the level of the fracture site. And open fractures, we have also complications at the level of the soft tissues, like muscles, the skin, of course, because that's the definition of the open fractures. Vessels, nerves may be also damaged during the open fracture. And the bone situation may be different. It's different when we have a fracture of type A, for example, with only 2 fragments, or when we have a comminuted fracture, and sometimes some of the fractures will be lost through the opening of the fracture, so compromising the continuity of the bone. So all these factors like contamination, comminution, and soft tissue damages will diminish the potential of the fracture healing. Again, here is a picture of an open fracture. We can see here this opening at the level of the ulna. There is a classification system of the open fractures which was imagined by Gustilo Anderson. So this Gustilo Anderson classification system is the most used classification system all over the world. So we have the same classification system here. This classification system depends on the energy of the trauma, the status of the soft tissue, and the possible bacterial contamination. So the type 1 Gustilo-Anderson recognizes low energy trauma fractures. The skin wound is usually small, not more than 1 centimeter in length, and the fracture site has minimal bacterial contamination. Type 2 is a medium energy trauma. The length of the wound would be more than 1 centimeter, but usually less than 5 centimeters. No devitalized soft tissues and medium contamination. Type 3A, so it was type 1, type 2, now type 3 has also some subtypes. So type A, 3A, is a high energy trauma with destruction of the soft tissue with lacerations and devitalization, and important contamination from the exterior inside the fracture site. Still, in type 3A, it is possible the coverage of the fracture site by suture. In type 1 and type 2, obviously, suture of the skin was possible in order to cover the fracture site. In type 3A, still is possible this coverage of the fracture site by primary suture of the soft tissue. The main difference between type 3 and type B, type 3A and type 3B is that in type 3B is a gross contamination of the fracture site, and is not possible the coverage of the fracture site. We need to bring some soft tissues from the neighborhood, usually muscles, but the skin cannot be sutured. So in a second surgery, we need to cover with skin the fracture site. Here is an example of this type of fracture. So we can see here, so the lack of skin, so the extensive soft tissue destruction that cannot be covered primary, only in the second surgery. And finally, type 3C, which in addition to what happens in type 3B, we have arterial lesions, which compromise the vascularization of the limb. Sometimes We need even to perform amputations in these patients if the vascular axis of the limb cannot be restored, or if we cannot apply a limb salvage procedure, we may be even obliged to amputate that segment of the bone. The treatment of these fractures will be done by surgical and chemical debridement. I've mentioned the debridement before. Wound closure, when it's possible. Anyway, it's important to cover not especially the skin, but to cover the fracture site by bringing, if necessary, soft tissues from the neighborhood, and also fracture fixation, which will be done always in this type of fractures by external fixator. Debridement consists in excision of the devitalized soft tissue, excision of the uh, foreign bodies which are at the fracture site, and also washing of the fracture site with chemical substances like saline and even some other antiseptic substances. The covering of the fracture site will be done directly when possible, or using flaps from the neighborhood, and in the second time surgery by skin grafts from the neighborhood for covering the granulation tissue. Fracture fixation will be done in type 1, 2 by using intramedullary nails. So in open fractures of the first and two types, we can use intramedullary nails like for normal fractures. We cannot do that from type 3, A, B, and C, of course. And in type 3, we must need an external fixator like I have mentioned before. So it is still a discussion in the specialty literature for the type 3A open 3A fracture, if it may be fixed by the intramedullary nail or not. Well, in our practice in Romania, we prefer to use external fixators also for the 3A in order to prevent infection at the level of the fracture. In other countries, especially US, in 3A, they still prefer, in most cases, intramedullary fixation nails doubled by a long-term treatment with antibiotics. Here is, again, an open fracture fixed with an external fixator, and also there are different stages of the treatment. You can see here the initial status of the patient, then fixed with the external fixator, closed but not the skin, and finally with the skin graft, and the final result with the complete closure of that fracture. So a successful treatment by using this step-by-step treatment. Okay, this was all for today. You'll have the practical demonstration now, which follows, and also tomorrow morning at 9 o'clock for the next lecture. Have a good day.
Thank you.
Thank you.
Thank you.
Thank you.